Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Death may seem like the antithesis to public health, but as Dr. Sandra Galeo, Boston University School of Public Health Dean once said, the data is clear. 100% of us will die. In a two-part series, Death and Public Health, we'll be exploring the end of life as a public health issue. Today, in part one, I talk with Dr. Jillian Tullis, a professor in communication at the University of San Diego, whose research focuses on death and dying in healthcare settings. We talk about how to talk about death and dying with loved ones, why the conversation is so difficult, and some tools for having these conversations. We also talk about how the COVID pandemic and a proposed bill in Congress for a national strategy on grief could help create some change needed for all of us to think about what it means to die well. Let's listen. Jillian Tullis, thank you so much for joining us on Public Health on Call. You are a professor with a focus on death and dying, and it might seem a little strange to talk about death on a podcast about public health, but death is a huge part of life. So tell us a little bit about your research and your work studying how people view and talk about death.
Well, first of all, thanks for having me. I really appreciate it. I have been studying how people talk of dying and death for quite some time. And I've always been interested in why the conversation is difficult for people. And so what I have spent time doing is trying to be in spaces and places where people have these conversations, such as hospitals and hospices, and sometimes in my classrooms, and thinking about why this is such a difficult topic for people to explore.
What have you learned about that?
Well, what I have learned is that it takes practice, for starters, and I think we are living in a culture that goes out of its way to try to avoid the conversation and to avoid the very idea of mortality. And so what happens is we don't have any practice doing it. We have spent more time avoiding those conversations until they become critical and necessary. So it is not until someone has died or until someone is seriously ill. And as a result of that, we struggle. We struggle to find, we think it's impolite to have the conversations. We think it's impolite to ask people what they want. And really, I think that what I've learned is that people are actually relieved when their loved ones, when their family members, when their physicians are willing to have open conversations about these issues.
So what kinds of conversations do you have? Like, what are these conversations where family members are talking with someone who's ill? Are they conversations, you mentioned like people asking people what their preferences are? How do you frame these?
So I have spent time researching and observing conversations about these issues in healthcare settings. So I'll first talk a little bit about healthcare settings, and then I can talk about what that looks like in the family context. In a healthcare setting, the conversations can sometimes be strained because the physician is very concerned and worried about causing emotions with their patients. They don't want to let them down. They may feel a sense of obligation to help them, like cure them, for example, if they have a disease like cancer. And so what happens sometimes is that the physician is reluctant to have the conversation, and they assume that the patient will ask them, will say to them, I would like to know how much time do I have? And then it becomes kind of it's described sometimes as a dance, or even a conspiracy, or a kind of dance of silence, right? So the physician thinks that the patient will ask, and the patient thinks that the physician will tell them. And so nobody says anything as a result sometimes of that kind of dynamic that's playing out. And so what I have tried to encourage people to do, if it's the physician, is to ask a patient what they want to know, and to then be honest with that type of information. In some cases, I've also encouraged, and a colleague of mine, Lori Roscoe, and I have encouraged people to have a conversation that looks at a broad range view. So we don't have to have a conversation about, we don't have to wait and have the conversation about dying until dying is happening. We can have a conversation now when maybe I've been diagnosed with a serious illness to like kind of chart and think about what my values are, what my preferences might be. And then when the time comes, perhaps that conversation is a little easier to have. So in contrast to that, or maybe another context that I've seen these conversations take place is amongst family members. So a family member might be getting older. Let's say it's a grandparent or a great-grandparent, and they say, I want you to have this precious bowl that is something that's an family heirloom. And what ends up happening is that the family member, the grandchild or the child will say, oh, grandma, you're not dying anytime soon. We don't need to have these types of conversations. And grandma is saying, no, like, I want you to have this object. I want to open the door to this conversation. And then they're thus shut down. So I try to, in those contexts, in those spaces, encourage people to see that as an invitation to have a conversation. It doesn't have to be a long one. It could be very brief. It could be something like, well, what would you like to see happen? Do you want to be buried? Do you want to be cremated? And then you can drop out of that conversation and return to it at another time, and or when the issue arises again. So I think it doesn't have to be all of our hopes and dreams and values and ideas about the end of life don't have to be explored in one conversation. We can have kind of little micro discussions that then leave us better prepared and informed. So we're better prepared to help grandma have the type of end of life experience that she wants. But also then we're a little bit more emotionally prepared for that inevitability.
What do you do in the event that a loved one is really resistant to this conversation?
This is a really great question. There are times when family members, loved ones just don't want to talk about dying. They're maybe superstitious about it. They don't want to deal with the emotions that come up with thinking about their own death. And so what I say is, if someone is very, very resistant to the conversation, take an example that isn't about you or the person that you're in conversation with. So for example, you may take some story from the news that you recently read about. You may say, hey, Mom, what do you think about this woman, Brittany Maynard, who moved from California to Oregon because she had a terminal cancer and she wanted to end her life on her terms? What do you think about medical aid in dying? And then use that as a way to have a conversation to understand this person's values around medical aid in dying. And sometimes it can soften the kind of, and take down the emotions a little bit, because now you're talking about someone who's not you.
And this is a unique time. We're just coming out of this period of significant grief and loss with over 1 million Americans that have died from COVID. There's actually a proposed bill in Congress for a national strategy on grief. There are calls for a national day for grief and bereavement. Do you see the conversation on death and dying changing in the future?
I hope that these are little signs that there will be some positive change towards accepting death as a natural part of life, but also supporting people who are grieving. I think that I wish I could say that it had happened sooner. I mean, that would have been my hope. But I'm glad to see that there's some efforts that are being made now, because I do think that, there's research that suggests that for every person that has died, there are at least 9 grievers. So if we take just the numbers in the United States of over 1 million, then we know that we have 9 million people who are grappling with grief. That is a lifelong experience, right? It doesn't end. And I think when we have had lots of deaths, and so we're talking about an accumulation of death experiences, and we don't have spaces and places where we can process those conversations or those experiences, then I think we kind of hamstring ourselves. We cause more damage to ourselves. So we're not only dealing with the grief, but we're dealing with the kind of aftermath of that.
Let's talk about some specific examples of, maybe let's call it the components of a good death. You mentioned that this can be like a series of conversations. So let's pretend that we have this ideal situation where you get to script it for a family, and we can go back to maybe the grandparent and the grandchild. What are the types of things that people should be asking? What are the types of things that people should be thinking about?
I think that's a really great question. I think that if we have a orientation towards dying well or having a good death, then we are going to be asking people questions about where they want to be, who they would like to have there with them, and if they have any concerns about things like pain or symptoms, and then also thinking about what happens at the time of death. Would they like people to do things like engage in like washing the body, for example, or prepping the body in some way for a funeral or a memorial service, and then thinking about the after, kind of what they call after death care. Does a person want to be buried? Do they want to be cremated? Would they like to explore, natural burial or something along those lines? So I think we can have a series of conversations that think about the dying process from the point at which we might think dying is happening, whether that is an illness or just somebody who's getting older and aging and slowing down, all the way through to what that funeral or that memorial looks like. So I say to people, find out, what does grandma think is really important? Is she worried about being in pain? And or is she worried about making sure that her sister is not in the room, right? So maybe there is also some boundaries that we can set up, because I think what ultimately we're describing here is that people want to have control, and they can have some control if they express their wishes. But too often, I think we assume that dying, at least as it relates to a natural death or even certain illnesses, that we think it's somehow out of our hands, that it's this mysterious process. But the truth is that we have a lot of information and knowledge about what happens to the body. And we also then can prepare, and we can be present if we would like to be at the bedside. And if that person wants us at the bedside, we can be there, and we can be with them when they take their last breath.
And there were a lot of people that, even if they had prepared for this and had this conversation, they weren't able to do these things, for example, in the context of a COVID death. So then maybe you have to have a different conversation. Like, is there a way to ahead of time say, like, if none of these wishes can be met, here's what I prefer?
I think there is. I think because you have to be a little bit prepared for the unexpected. I mean, as much as we know about the dying process, there is always something that can go wrong, right? You can always have something that's unexpected pop up. And I think that if we can have a sense about, that's why I also think we need to have multiple conversations. If we can have a sense about what someone's general wishes and general values are, then we're better able to be prepared when we can't be present for the death, or it doesn't happen in the way that we expected. So I know, for example, I have some general sense about what my mother's wishes are for her end of life. And so I know that if I can offer her some little moments of comfort, even if I couldn't be there, to maybe if I were have to FaceTime, for example, with my mother, instead of being present in the room, that I know I can still relay messages that way that would be helpful for her, at the very end, to let her know that I'm going to be okay, even if I can't be present with her. So I don't know. Hopefully that answers your question a little bit.
I want to thank you for your time. The end of life experience is universal. And I think the more we talk about it, and the more people like you can help us, give us the tools that we need to have these really difficult conversations, the better it is for everybody. So thank you again so much for your time.
Thanks for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.